And I have 12:01, so we are going to jump right in so that we can make sure our speakers have plenty of time for their presentations. Um, Want to welcome you guys to Conversations with an Expert. This episode is going to be, excuse me, Understanding Human Trafficking for Medical Professionals. It's part one of a three-part series. I'm Carla Jacobs. I'm with the Georgia Commission on Women, and I am the chair of Work Group 1. So we want to welcome you all here today to this important meeting. Just a few housekeeping things I want to go over. This is going to be recorded and it will be available on our CJCC YouTube page in a couple of days. And we want you to feel free to share that far and wide with anyone in your network who wasn't able to attend the meeting today. We will be taking questions at the end of the meeting. We'll be using the chat for that. So if you have questions, pop them in the chat and we will be keeping up with those and we'll be asking our presenters those questions after their presentations. And anything that we don't get to, we're going to be collecting all of these questions. And in part three, we're going to be doing a panel discussion and we will get to all the questions that we collect during this three-part series during that panel discussion. So please feel free to drop a question in the chat and we will address those at the very end of the presentation. Do want to give a little bit of a content warning. Some portions of this training may involve sensitive and uncomfortable topics. For attendees, please feel free to step away, take a self-care break if you need to during this presentation and come back to us. So again, we are very excited that you guys are here. I'm going to go ahead and introduce both of our speakers at the top so that they can just jump right in to the presentations. Our first speaker is Dr. Angie Boy, and she is the Program Manager for Prevention and Education at the Stephanie V. Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. In this role, she's responsible for overseeing the implementation of multiple projects related to child abuse and neglect, including child sex trafficking, prevention of child sexual abuse, and mandated reporting of child abuse and neglect. Dr. Boy also sits on several state-level work groups, including the statewide Human Trafficking Task Force and the Child Fatality Review Project. She also works with other community organizations to address training and education needs around adverse childhood experiences. Dr. Boy has a doctorate in public health with an emphasis in maternal and child health from the University of Alabama at Birmingham and a master's in public health from the Mercer University School of Medicine. She has over 20 years of experience in the field of family violence and has a special interest in the impacts of family violence on mothers and their children. Dr. Boy, thank you for coming and welcome. Our second speaker today is Sarah Pedersen. Sarah Pedersen currently serves as the statewide Sexual Assault Nurse Examiner Coordinator for the Criminal Justice Coordinating Council. In this role, Sarah coordinates and supports existing and developing SANE programs throughout the state of Georgia. With Ms. Pedersen's support, the CJCC promotes consistent, professional, and patient-centered medical and forensic response and treatment of sexual assault victims across the state. She also coordinates training to create opportunities for continuing education for SANE nurses and other disciplines within the sexual assault response team. Ms. Pedersen has a Bachelor of Science in Nursing from Kennesaw State University. In addition to holding credentials as a registered nurse and certified SANE A, SANE P, and AFNC, Ms. Pedersen is currently pursuing a psychiatric mental health nurse practitioner degree from Georgia State University. Welcome, Ms. Pedersen. Thank you so much for being with us today. So I'm going to turn it over to our speakers. Dr. Boy is going to take the reins first. And again, we appreciate you guys being here and look forward to what we're all going to learn here together. So take it away, Dr. Boy.
Great. Thanks so much for having me today. Like Carla said, I'm going to get started with the basics of the presentation, the intro piece. And oh, there we go. Sorry, tech was giving me some issues. This gives you the overview of what the series as a whole is going to cover. We're not going to get to all of this today by any stretch, but I'm going to start with the basics. We're going to get an overarching definition of human trafficking and look at the scope of trafficking both nationally and here in Georgia, and look at some of the risk factors and pathways to entry. And then I'm going to transition it to Sarah, where she is going to get into the details of the actual intersection between trafficking and healthcare and look at some of the barriers that are encountered and what the clinical presentation is when victims are reporting for and seeking healthcare services. So let's start first with the definition. Human trafficking has a very broad scope, and what we have determined is that there are kind of two buckets that we look at. There's the sex trafficking bucket, that is the recruitment, harboring, transportation, provision, obtaining, patronizing, soliciting, or advertising of a person for a commercial sex act, in which that commercial sex act is induced by force, fraud, or coercion, or in which the person induced to perform such an act had not attained 18 years of age. We'll get into more details about that. That's a lot of words. Then labor trafficking is the same things, but it is designed specifically for and around involuntary servitude, peonage, debt bondage, or slavery. So you have sex trafficking, labor trafficking, and then there are times where you have victims of both. Looking at language, you may have heard the term DMST, which is domestic minor sex trafficking. So that is the recruitment, harboring, transportation, etc., for commercial sex acts where the person is a U.S. citizen or lawful permanent resident under the age of 18 years. So a lot of organizations in Georgia and a lot of organizations nationally will talk about serving DMST survivors. And that is a narrow piece of the larger group of trafficking victims. In healthcare, we generally are referring to commercial sexual exploitation of children, which is sexual activity involving a child in exchange for something of value or promise thereof, treating the child as a commercial sexual object, but it does not have that limitation of someone under the age. Someone who is a U.S. citizen or lawful permanent resident. Because here at Children's and in other healthcare organizations, we treat all comers. We don't delineate. That's the main difference. Other organizations may be limited by their funding organizations and are limited to only being able to provide services to U.S. citizens or lawful permanent residents. So there's that difference there that comes into play. But know that when we're using those terms, we are talking about the same group of children. So when we look at the action, means, and purpose around child sex trafficking, around sex trafficking in general, you have the action. So someone is actively recruiting, someone is transporting, somebody is providing a victim for sexual acts to someone. They're obtaining the victim, they're making all of the arrangements, they're soliciting for buyers. So you've got an action. Then over the age of 18, you've got to have force, fraud, or coercion. So there's physical force, sexual assault, confinement. There are false promises that may have been made. They may bring someone to an area promising them a modeling job, for example, but there was no modeling job. They may have offered them a domestic type role as a housekeeper or a nanny, but that job doesn't exist. Then there's coercion. They may threaten them. They may threaten to call law enforcement. They may have charged them so much money to bring them to the United States, to bring them to a new state, and now they're having to work off that debt. There may be psychological manipulation. They may confiscate any documents that a victim may have. And then the purpose is for either commercial sex or that labor. Now, the difference when you're talking about those under the age of 18 is you don't need force, fraud, or coercion. A child under the age of 18 cannot consent to commercial sexual activity. So they are automatically considered a victim, whether or not there is force, fraud, or coercion. Now, with labor trafficking, you do still have to have the force and coercion aspect to it to be considered a victim. But with commercial sexual exploitation, you don't have to have that. So it's important to know that if you are working with children or volunteering in an organization that serves children, you are a mandated reporter. And child sex trafficking is considered child sexual abuse in the state of Georgia. So it falls under Georgia's mandated reporting requirements. You are legally required to report your reasonable suspicion to DFACS. The idea is that the person who identifies the abuse is the one calling, but we recognize that organizations usually work under a designated delegate system where the manager or, excuse me, the director of the organization is the one who makes the report. That's fine. The issue is that the report has to be made within 24 hours. If you are concerned that that child is in imminent danger or there is some form of an emergency, you want to call 911 and call DFACS. Oftentimes we get questions, well, what about adult victims? We know that, this adult female is being victimized. Mandated reporters are only required to report abuse and neglect of at-risk adults in the state of Georgia. So that includes adults with mental or physical disabilities and adults 65 years of age or older. So if you are working with someone who has a developmental disability and you have concerns that they are being trafficked, then you would call Adult Protective Services, and that phone number is on the screen, and then press option 3. There is no reporting for abuse or exploitation for other fully competent adults in Georgia. So you may know it's happening, but if you don't have the victim's consent, you cannot make that report. You can certainly encourage and assist them in getting in touch with law enforcement, but you cannot call and make that report. So let's look at some national pictures with human trafficking and how things stand up in the US. The Polaris Project is the operator of the National Human Trafficking Hotline, and you can see their website on the screen. I would encourage you, if you're interested and want more details, check out their information. They collect an amazing amount of organization, and they are wonderful, amazing amount of information, and they are wonderful about sharing it. And they put out reports on a regular basis. And so we know that they are responding to a high number of calls in any given month. You can see on the screen over 4,800 calls a month to the trafficking hotline. They're assisting survivors. They're connecting them to local resources. They're providing those referrals. And you can see that in their reporting, that 66% of the victims in a given month are victims of sex trafficking, 13% are victims of labor trafficking, and 6% are victims of sex and labor trafficking. So you can see that this is a significant number of people reaching out in any given month and getting assistance from the National Human Trafficking Hotline. Now, Georgia is fortunate that we have a state hotline that is operated locally. And so you don't have to go through the national hotline just to get back connected to Georgia resources. You can reach out via the 866 END HTGA hotline. And we know in their most recent reporting that they received calls from 141 of 159 of Georgia's counties. So that is evidence right there. And we'll talk about some of the myths in just a minute, but that's evidence that trafficking in Georgia is a statewide problem. It's not an Atlanta problem. It's not a Savannah problem. it's a state of Georgia problem. And so you can see from the jump from 2022 to 2023. So getting the number out and making people aware and having the number posted in a variety of different areas is paying off. People are reaching out for services. And in Georgia, children are served by the CSEC response team at the Child Advocacy Centers of Georgia. So they work to respond to underage victims, so those under the age of 18. And they served 749 youth in 2023 and provided a wide variety of different services. The average age of the victims they served in 2023 was 14. So you think about what that has to mean in terms of the age of victims and how many children are being served, and then how many children are being victimized in our state. They provide case coordination. They work to make sure forensic interviews are done. They provide a wide variety of services for victims once they've been identified and connected. So you can see some examples of cases of, we'll go through labor and sex trafficking, but here's a case of labor trafficking in Georgia. In 2018, there was a multi-agency investigation that was looking into human smuggling and labor trafficking by a criminal organization. And so this is organized crime that has moved into trafficking in people, just like they traffic in drugs and weapons. The investigation was looking into the working conditions of Mexican and Central American workers on South Georgia farms. And in 2021, a 54 count indictment was handed down for 24 defendants for their roles in labor exploitation and visa fraud. So you can see it takes a long time to do a lot of these investigations. And so what they were doing was making workers pay huge amounts of money for transportation, food, and housing, and they were illegally holding their travel documents and identification. So they were forcing them to work in crowded, really unsanitary conditions, and were alleged to have made over $200 million from the scheme that they were running. So you can see this is one instance of labor trafficking in the state of Georgia. Looking at sex trafficking, there are multiple cases. We just picked one to highlight here. In 2020, Operation Not Forgotten was a multi-jurisdictional investigation that found a 17-year-old in a Fulton County hotel room who'd been reported missing from Kansas City. Her trafficker pleaded guilty in 2023 and received a 25-year sentence, 13 of which are to be served in prison, and 9 buyers have pled guilty. So in this instance, they weren't just going after the trafficker, they were going after the buyers as well. Let's touch a little bit on some of the common misconceptions that come up when we're talking about CSEC. One of the big ones we hear is that only girls are victims. And what we know is that we generally serve more females than males, but we recognize that there are male victims. Their presentation can be very different. How they respond to offers of service and help may be very different, but we recognize that there are male victims. And so it's important that we think about trafficking as being something that impacts both males and females. Another one is that only poor people or immigrants are victims. We know that traffickers prey on vulnerabilities, and we know that all teenagers have some level of vulnerability. So the fact that we are ignoring possible vulnerabilities in teenagers because we think that this would never happen to them, they live in a wealthy zip code and they don't have, they don't have to do things for money, or they don't have to, sell themselves or whatever we're telling ourselves. The reality is they have vulnerabilities just like everybody else. And so we have to be aware and be offering services and awareness and education to any and all students that um, we can encounter, and making sure that we are educating all of our youth on the risks and vulnerabilities related to abuse and trafficking. Human trafficking doesn't occur in the US. We've shown just from the couple of examples here, and there are hundreds of other examples, that trafficking happens all over the world. And it is happening in the United States. It's happening in Georgia, both in urban and rural areas. It's happening here. Whether we want to admit it and do what it takes to address it is a different story, but trafficking does happen in the US. Another one is that all traffickers are male. We know that there are female traffickers. There are females that may be operating right up under a male trafficker, but she is the one actually doing all of the coordinating and recruiting and is serving as the trafficker. Um, we know that they're not all male. So it's important to be aware of that, particularly when you are working with patients and you may have a situation where a patient is accompanied by an unrelated female, that you still are giving thought that the female in the room might be the trafficker. The other one we hear a lot of is that you choose to get involved in the life, or that they must be forced into the commercial acts to be real victims. Um, no 13-year-old wakes up one morning and says, "Oh, I want the newest iPhone. I'm going to go sell myself for sex this afternoon, and I'm going to make enough money to get myself the new phone." It's not how it happens. That's just not how it happens. Nobody chooses that this is the way that they are going to uh, operate in life. There are a wide variety of vulnerabilities. There are a wide variety of factors that impact how a victim is brought into the life. Oftentimes, particularly with teenagers, they are unaware that they're being groomed. They don't realize what's happening to them. They think they're in this relationship and they're doing their partner a favor, and then they are all of a sudden now being trafficked, and they feel trapped in the environment. So they don't have to be forced. It's not, uh, they're not being kidnapped by the guy in the white van in the Walmart parking lot. That's not how things are happening. Uh, Human trafficking victims aren't necessarily going to be excited to be rescued or saved from what's happening. They have been involved in this. They may have bonded with their trafficker, and we'll touch on that in just a minute. They may be afraid to go back to the environment that they were in. They may love the person that is trafficking them. There are a wide variety of reasons why victims may not be so eager to be rescued. We've already talked about sex trafficking is not just a Metro Atlanta problem, that it happens all over the state. And then the other one is that relatives can't be traffickers. And that sort of plays into the familial trafficking pathway to entry. We know, according to Polaris, 26% of reported trafficking was familial. And there are a wide variety of different examples that we see in Georgia. There's one example of a family who was selling their daughter to pay for their Dodge Caravan. We've seen other instances where parents may be selling their child to get access to drugs or money for drugs. There are a number of different examples, but familial trafficking uh, is being more increasingly identified by organizations that work with trafficking victims. We also know that around 22% of trafficking is done by an intimate partner, titled Romeo trafficking. And so an intimate partner has built that relationship with a victim, and then begins to traffic them out. And so we see that. We see social media being a pathway to entries. A trafficker will identify a vulnerable youth on a social media site, and they will begin to groom them and attempt to make contact, and then it goes from there. We see sextortion happening, where a child may send an inappropriate picture, and the perpetrator will threaten them with exposing the picture unless they do whatever. And that is another entry into trafficking. Again, false promises of employment. We see that, modeling jobs, acting jobs, things like that. But then we also will see um, some labor trafficking pieces where they start out with what looks like labor trafficking, but then moves into sex trafficking as well. And then peer recruitment, where victims will recruit fellow students in their high school, or they will recruit friends to um, be involved in the life as well. So we see a wide variety of different pathways to entry into the life. Oftentimes, there can be more than one pathway. So it's not, again, it's not as simple as, oh, I'm going to do this and this will happen. There are multiple different avenues of entry, and the vulnerabilities may differ and will end up leading to different pathways. So when we talk about the victims as a whole, we know it can be adults and minors. They can be foreign nationals or US citizens. We've talked about that. They can be any gender identity. So you have males and females, you have uh, trans victims, you have victims who are members of the LGBTQIA plus community. It doesn't matter. Everybody, um, regardless of socioeconomic status, regardless of education, documentation status, anybody could potentially be a victim. We know there are some particular vulnerabilities that put people at higher risk. Homelessness is a big one. Prior abuse or violence. Oftentimes, children who have run away may be fleeing violence in their home. And so they would rather take a risk on the street than stay at home and continue to be abused. So we know that being homeless increases the risk for engaging in what is termed as survival sex, where they are exchanging sex for shelter, food, things like that, that are needs for daily life. If you only have temporary protected status, that can lead to greater vulnerabilities. Traffickers may be preying on that vulnerability and promising help with immigration. Um, Substance abuse, poverty, mental health concerns, disabilities may lead to greater risk, particularly developmental disabilities, because that may lessen a person's ability to make decisions about what is safe and riskier behaviors. And then family dysfunction. If the family is struggling, if there are issues with violence in the home, like I mentioned, um, a child may be more likely to flee and to run away from home, trying to escape the family dysfunction. When we talk about sex trafficking in particular, we know there are risk factors that can increase the likelihood of victimization from sex trafficking. So we know, again, it's some of those vulnerabilities that we just mentioned. But prior sexual abuse in particular increases the risk for trafficking. Some research has shown up to 90% of trafficking victims have a history of sexual abuse. So the exact rate varies depending on the study you're looking at, but some studies have shown as high as 90%. So when we're thinking about prevention and we're looking to try and stop trafficking, backing up, and let's stop and prevent the physical and sexual abuse, we are lowering the risk factors. Um, Homelessness and poverty, lack of education, being part of a socially marginalized group can increase the risk, and then a history of being involved in one of the systems, so juvenile justice system, foster care system. Those youth have vulnerabilities that traffickers know how to exploit, and so those groups in particular show an extremely high risk for being trafficked. Then some of the same risk factors play over into labor trafficking. With labor trafficking, immigration status is more of a risk factor because the trafficker can exploit the fact that they may not be in the United States with documentation, or they may hold the immigration papers and the documentation, and the person that is working for them doesn't have access to it. And so that puts them at risk for being detained and questioned, and then they don't have a way to prove their documentation status. Certain members of the diplomatic staff can have diplomatic immunity, and so there are limited protections for labor trafficking victims if the perpetrator has diplomatic immunity. So it can be a complicating factor. Um, and then lack of employment or labor opportunities in their home country, um, political unrest, war, things of that nature will drive people into other countries and put them at risk for labor trafficking. That happens in the United States, but it also happens around the world. That upheaval in countries of origin can lead people to seeking work in other countries. So let's talk a little bit about grooming and how a trafficker will approach a victim and can then force the um, victim into the life using their grooming tactics. So they're going to methodically work to gain trust. Again, this is not a movie scenario where, a trafficker will come in and kidnap. This is a methodical building of trust. They're going to try and create dependence on themselves. They're going to promote the idea that what they're asking a victim to do is normal, acceptable, and necessary. So what it results in is vulnerable people cooperating in their own exploitation, and thinking that they've made the choice to do that. So we know that they are loosely cooperating. They've been groomed to think that what they're doing is fully their choice, and they know what they're doing. They can leave anytime they want. That's what they believe. We know the reality is very different, particularly when you're talking about children. So there are lots of different stages, and how quickly a person will move through these stages is going to depend on the victim. It's going to depend on the trafficker and what the scenario is. If they're meeting online, a lot of these stages move much quicker than if someone is doing the grooming in person. So ideally, a trafficker is going to target, they're going to identify a vulnerable person that they want to try and exploit. So they're going to attempt to make contact. And once they do that successfully, they're going to begin to gain their trust. So they may make flattering statements. They may encourage them and, you know, offer them small gifts, things like that. They may take them out on a date or something of that nature. They're going to attempt to meet those needs, whether it be technology, new clothes, food, shelter, things like that. They are going to have identified back in the targeting stage what exactly the vulnerabilities are. Then they're going to begin to isolate their victim. Um, in some instances, they're going to convince their victim to run away. and come live with them, but they're not going to allow the victim to continue to have relationships with friends. They're going to limit who they can talk to, limit the amount of time they can talk to them, things like that. Then they're going to begin the exploitation process, and begin to repeat it. And then they're going to work toward maintaining control. And that maintaining control can be a lot of different things. And that, again, is going to vary depending on the victim, but it could be violence. It could be increased promises for, um, gifts and things of that nature. It could be threats against the victim's family or friends. It could be threats of further exploitation, whatever the trafficker needs to do to maintain that control. So you can see the stages happening, and they look different depending on, um, what kind of exploitation. So it may be that it starts with, images and the generation of child sexual abuse material, what's also known as child pornography. And then it escalates into physical contact, and sexual activity. Again, the control and the isolation all vary depending on scenarios, but the stages generally follow this path. Um, and it plays out the same usually with adults and children. Um, the issues of how they do their approaching differ slightly, but these stages of grooming play out, across the board. And one of the hardest reasons, or the hardest things about working with victims and approaching a victim for services, we talked about they're not always eager to be rescued. That's because a lot of times they've built trauma bonds. So this is a connection or relationship between an abused person and their abuser. And so some of the signs that you may see when you are working with victims, they may agree with the abusive person's reasons for the abuse. They may make excuses for the abuser. They may argue or distance themselves for people trying to help. So somebody in the medical field, they may not want that help. They may become defensive or hostile, and they're reluctant or unwilling to leave the abusive situation. So this is a psychological response that victims are having. It's not so much that they don't want help at all. They just are struggling with the fact that they have this relationship, and how do they work through the relationship, and breaking that relationship to get to safety. So with that, I am going to turn it over to Sarah. I'm going to stop sharing my screen and allow her to take it next.
Good afternoon, and thank you, Dr. Boy. Are you guys able to see my screen okay? Okay,
Yes.
so we're going to transition over now into how this applies into medical settings and how this might look when the patient presents to us. The medical professional plays a really crucial role in identifying victims of human trafficking during our medical encounters. Healthcare settings are one of those opportunities where victims will interact potentially with professionals who might recognize these signs of trafficking. According to a report that was published in 2018 by Polaris, and this was the on ramps, intersections, and exit ramps, this report showed that 69% of study respondents reported that they accessed health services at some point during their exploitation, making healthcare one of the most common professions trafficking victims encounter. Despite this, 57% of survivors reported they were never asked trafficking or abuse screening questions during any healthcare visit. This statistic highlights the need for increased awareness and training among medical professionals to properly screen for signs of trafficking and offer critical interventions. So building on the opportunity for this intervention, it's essential to understand why victims and where victims may seek medical care. And you can see on the left the bar graph that shows those top four places. which are emergency treatment facilities, women's reproductive services, primary care treatment, or places for mental health services. And these visits often are tied to needs that might mask their underlying exploitation. The Polaris report also reported that victims, when they're coming in, for example, to an emergency treatment for acute illness or for injuries, that they might be presenting with untreated infections or injuries that are related to the violence or other health emergencies related to their exploitation. When reporting to women's health reproductive services, it could be for reasons such as seeking birth control or testing for sexually transmitted infections, pregnancy care, abortion services, reflecting also the reproductive control that may often be exercised by traffickers. When they're presenting to primary care treatment, for example, victims may appear for routine checkups or even for care of chronic conditions like asthma, hypertension, or diabetes, often without disclosing the exploitation that they are enduring. Mental health and substance use concerns are high rates of trauma-related mental health issues and substance use are common as traffickers are frequently using or may frequently use drugs to control their victim, or it's being used as a coping mechanism for the abuse that the victim endured. Given these challenges in identifying human trafficking, we as medical professionals still should remain with our eyes open, look at the patient, listen to the patient, address our response with thorough assessments so that our patient interactions and the things that we're gathering from that time with our patient can give us information to really guide essential care that they need. With behavioral observations, pay attention to how that patient is behaving during the visit with you. They may appear anxious, submissive, or afraid, fearful, especially if they're still around the trafficker. And many times that trafficker may insist on remaining present during the medical evaluation. The patient might avoid eye contact, they may seem guarded, or they may be deferring to someone else to speak on their behalf, even for basic questions that we would expect a patient to be able to answer regarding their health history. Reported also for some of those potential concerns with behavior or are some repeated healthcare visits when they're coming in for injuries or conditions and when what you're seeing does not match with the history. That's another thing that should raise a red flag in the medical setting. When we're talking about verbal cues, we want to make sure that we're listening carefully to what the patient tells us, especially how they describe their work, their living conditions, or relationships. They may mention working, for example, excessive hours, not having good control of their identification or their money, or describing an environment in a way that does hint at this coercion or control. Even without direct disclosures, there may be fragmented or inconsistent narratives about the injuries or other personal circumstances that you're observing that could suggest exploitation. And with physical findings, this is in that physical assessment where we really want to ensure the head to toe thorough visualization, because physical assessment, that's where we can see certain physical signs that also may point to trafficking, including untreated or repeated injuries, malnutrition, maybe bruising and unusual patterns or signs of physical restraint. Poor personal hygiene or lack of access to basic needs might indicate also control by another person. In cases of sex trafficking, there may be evidence of repeated sexually transmitted infections, pregnancy, or even visible branding or tattoos that imply ownership. When something doesn't feel right, however, trust your instincts. If you're sensing that something is off, even if you can't pinpoint it, don't hesitate to seek further guidance. You can get an expert opinion from social workers, human trafficking response teams, or professionals trained in that trauma-informed care response. In a nutshell, it's always better to explore concerns than to let a possible patient suspected of trafficking leave without intervention. As healthcare professionals, when we are when we're really ensuring that we take these things in the behavioral observations and verbal cues and physical findings and recognizing some of those potential indications, that as healthcare providers is what we may be providing to that victim, our patient, as potentially their only chance to escape exploitation. So we're going to move to the next slide and we're going to apply this to a case. However, I do want to note that these next few slides with the tables, while they do list several things that you might note in the different categories, these are things that we recognize in the field as potential indicators or red flags. They are not diagnostic, nor are they inclusive lists of everything. So let's break this down first. When we're talking about behavioral observations, we have our patient, Emily, 22 years old, comes in for care. And when she comes in, she is very guarded. She appears to be fearful. She's avoiding direct eye contact with the staff and seems anxious whenever her companion speaks or looks at her. She's also deferring to her companion when asked simple questions about her symptoms and her medical history. She looks to the companion, her male companion that's with her, for permission to answer or allows him to answer on her behalf. Emily's going to provide inconsistent details about how long she's been experiencing symptoms, and she's going to also frequently change her timeline, and she seems confused. When asked about her living conditions or work, Emily is vague, mentioning that she stays with friends sometimes, but she quickly changes the subject. She mentions working late nights, but is unable to provide details about her job or who her employer is. When asked for identification or insurance information, her companion produces her ID and keeps hold of it, stating that he manages her personal documents for her. Upon your physical assessment, it is noticed that Emily has bruises on her upper arms and on her back, and she provides an inconsistent explanation of the causation of this bruising, stating that she just bumps into things. Some of the bruises that you note appear in a pattern that suggest potential or possible restraint. Emily reports recurrent UTIs, and a pelvic exam reveals signs of untreated sexually transmitted infections. And when asked about her sexual history, she's very reluctant to provide details and avoids the topic of contraception or consent. She appears to be underweight, has poor personal hygiene, and worn clothing that doesn't seem appropriate for the weather. The healthcare team begins to suspect that Emily may be a victim of trafficking. And can you see why? There are several things that they have pulled out that we have just discussed that fall into some of those red flags that are concerns when it comes to a patient's behavioral presentation or verbal communication or things that they're saying to you, and then some of the things identified in the physical assessment. So recognizing that Emily may be in this vulnerable situation, this medical team contacts a social worker trained in human trafficking cases, and the social worker arranges for the male companion to be separated from Emily under the pretext of further medical testing. And once alone, Emily is asked more targeted in a trauma-informed way questions about her safety, relationship, and whether she feels that she has control over her own life. And she eventually discloses that the male companion is not her partner, but someone who controls her movements, takes her money, and coerces her into sex. The healthcare team does now coordinate with law enforcement and social services to provide immediate protection and connects Emily with resources for trafficking survivors, including safe housing and medical care. So this is the ideal outcome, that the medical team was trained to understand what that presentation may look like in the clinical setting. And with a team and interdisciplinary response, they were able to provide that safe environment where Emily was able to disclose. But the reality is, we know we're less likely to get a disclosure. That is not something that happens in every patient encounter. And we know that they're presenting in healthcare settings. While the identification can be challenging, even when we are identifying things or there's elements of their history that are the definition of trafficking, there's some barriers that can be a challenge in the healthcare setting. And one of those is that the patients may present with risk factors, but they're not disclosing. Your patient may display this physical or the psychological signs of trafficking, maybe those untreated injuries or the infections or other signs of trauma, but they are not offering details, for example, about their exploitation, especially if that trafficker is there or they're afraid of what might happen if the trafficker is aware that they are disclosing or getting some sort of help or raising any red flags with the medical team. Also, your providers might not always recognize these signs without knowing that full context of the patient presentation, or if they're not asking the right questions. You might have a patient that does disclose details, but they, even though these details are the definition of trafficking, they do not identify as being a victim. Some patients describe their situation. They might be mentioning forced labor or violence or coercion, but they're not seeing themselves as a victim. They may not use the term trafficking, which makes it harder for medical professionals to connect the dots. Okay, so there's also a few other barriers that are in the medical field that can prevent the provider from recognizing those potential signs. You may have healthcare professionals that are facing time constraints. It's very busy in medical settings. There are responsibilities to see many patients in oftentimes very short periods. And if there are not routine screening tools or signs that are recognized of trafficking, that patient might fall under the radar. These things might not be noticed. Lack of training is another huge barrier. Many medical professionals have never received specific education on how to recognize human trafficking. Additionally, bias or preconceived notions about what trafficking looks like can prevent medical teams from identifying patients who don't fit that stereotypical image that they think trafficking would look like. Or fear of overstepping may also be a concern. You may have some providers or medical professionals that are hesitant to ask some of these more invasive or deeper questions because they're worried about potentially offending patients or even getting involved in legal issues. So as we went down through Emily's case study, that case study highlights the important role of the healthcare provider with the healthcare team and how, as a team, they are identifying and supporting the patients that come in that are suspected or even disclose human trafficking. And with that appropriate action, medical teams can help our patients get the care and the protection that they do need. So to reinforce some of these key responsibilities for medical professionals and how we can facilitate that environment for our patients when we have a high suspicion, we've recognized some of these indicators, or maybe there is some disclosures. You want to talk to the patient alone. It's essential that we are separating the patient from any accompanying individuals, especially when there may be signs of control or coercion. This will ensure that patient has a safe space to share any concerns that they may have. We also want to know the risk factors and those potential indicators for trafficking. Some of those things we have gone over in our previous slides. We want to understand that patients' behavioral, verbal, and some of the physical signs of trafficking that we're seeing is really going to be guiding for everything else that we can do for that patient. We want to ensure that medical teams are trained with what those risk factors are, and understand some of the significant things that are associated to, for example, inconsistent personal histories or those unexplained injuries or someone that might not have control over their personal documents. Screening is also another important thing in the medical setting for so many different things, right? But there are screening tools available for human trafficking as well. We want to ensure that we are incorporating screening questions for trafficking into our assessments. And those screening questions can ask things about living conditions, employment, the control over finances, and relationships. We also want to stay true to what we are as medical professionals. We are there for medical care needs. What is the chief complaint? What is the emergent issue? While it is absolutely important to address trafficking concerns, we don't want to lose sight of some of the reasons why they came into the hospital. Always treat that patient's medical need, and we will treat medical needs as a priority. This help when we are staying true to our role as medical professionals will help hopefully build some trust in addition to providing that necessary care that that patient might not have received otherwise. We also want to ensure that we are offering any appropriate referrals once trafficking is suspected or disclosed, provide the patient with access to appropriate resources. That can include things such as social services, trauma-informed counseling, law enforcement. So we want you to be aware of what resources are in your area. At the end of this presentation, Dr. Boy is going to go over some of the resources that are here in Georgia and also some of the national resources. And then, of course, we do want to be aware of what we need to do for reporting anything that falls under mandated reporting laws. So if the situation involves abuse or exploitation of minors or falls under other mandated reporting categories, we should always ensure that we are taking the appropriate legal steps, following what our protocols are to make that report and to document. In fact, sometimes just those suspicions that fall under mandated reporting may be that first step to even being able to help provide some protection to that patient and also initiating further investigation. All right, so as we begin to wrap this up, we wanted to leave you with a few screening tools. I told you already that screening tools are important, and there are screening tools already that are out there for us. And here's an example of some screening tools, and these are validated screening tools that will help us apply trauma-informed principles to identifying children and youth who have experienced trafficking. And you can see that it's broken down to a tool identifier that is a in-depth one or one that's going to be a little bit quicker to deliver. It breaks it down into what environment it would be appropriate for this screening tool and the demographics that it would be appropriate to deliver to. So this is something that you can find by going to hhs.gov. I believe the link is at the end. If not, I'll make sure it gets dropped into the chat for you so you can go and see what the screening tools are. And there's also links to all of these screening tools as well. And this is another screening example. I actually really like this one. This one was created by experts in the field that I would believe many of you are familiar with. Dr. Jordan Greenbaum and Dr. Marnie Dodd created this screening tool for child commercial sexual exploitation and sex trafficking. This is the suggested introduction, and I'm actually going to read through it with you because there's 4 things that are happening here in this introduction that I believe are applicable across the lifespan in a lot of different scenarios with patients, just to set up the conversation for any potential screenings we may need to introduce or tough topics that we might need to discuss. So first, introduction of self and role. And the screening introduction states, hello, we often ask teens some questions to find out a little bit more about what's going on in their lives. It helps us understand more about how we might be able to offer help. And the second thing that this begins to go into now is empowering the patient. What is it that they can control? What's going to happen? What will they say to you, and how that might be applicable to the care plan that may be devised. So some of the questions are sensitive and may make you feel uncomfortable. So it is important to know that you do not have to answer the questions if you don't want to. If you decide to answer them, it will help us with your evaluation. Answers to some of these questions may be included in your general medical record, but the form itself will not. So empowerment. And then the third thing is full disclosure of limitations of confidentiality. And this should be done upfront. We want to let patients know before what we would have to do with information they give us that we might have to report. It's much better for patient trust and rapport when we're delivering that upfront and not hearing a disclosure or something and now saying, oh, by the way, I have to report this. So the example they give here is there are two exceptions to this. I'm sorry, let me back up 1 minute. It says, I am generally able to keep what you tell me private or confidential, but there are two exceptions to this. The first is if you tell me there is a threat to your safety or the safety of someone else. The second is if we are required by law to share information in our medical record. And then the fourth thing here is following up, giving them the time to ask any questions. And through my work as a SANE and also through the studies as a future psychiatric mental health nurse practitioner, I've learned that how we frame our questions is very important. And a great way to frame questions at the end of a situation like suggesting an introduction or a patient encounter is in an open-ended way. Instead of saying, for example, you don't have any questions for me, do you? Or do you have any questions? That's eliciting usually a yes or no. Ask it in an open-ended way that shows you're open to questions, you expect questions, and you have the time to answer them. So, what questions do you have for me? So 4 ways with this screening tool example of how we can basically introduce a screening tool that we may be using or a tough set of questions that we might be asking for history. And for this screening tool, you see there's some questions specifically that are attached to that Greenbaum-Dodd CSEC screening tool. And this would just guide what you would do for additional referrals or connections with different community partners. So what's next then? You've done your due diligence, you have the education, your team's been trained, a patient presents, and you know what some of those red flag indications may be through how the patient's behaving, any verbal cues, and also physical finding assessments. When a patient discloses or you have enough information that indicates potential trafficking for both minors and adults, follow your agency's procedure for reporting suspicions of abuse and neglect. Understand what the mandated reporting laws are here in Georgia or wherever you're practicing. And when in doubt, always call the statewide human trafficking hotline. Dr. Boy is going to provide that information to you when we get to the resources here in just a minute. And when we do use that hotline, you can be connected to other appropriate professionals to continue that response to the patient. All right, so my last slide, as we wrap up, I want to bring it all together. And the key points, these things that I want you to really take out of this when caring for patients who may be victims of human trafficking, are things that are really going to help ensure that the best possible care is provided to them without causing further harm. Always stay in your role. Remember, as healthcare professionals, our primary responsibility is to provide medical care. We are not investigators or law enforcement. Our role is to assess, identify, treat, and refer patients to appropriate resources. Focus on recognizing potential signs of trafficking. We want to treat the patient's immediate health concerns and refer the patient to the right resources or external partners whenever necessary. Always approach patients with a trauma-informed mindset. This means understanding that they may have experienced significant abuse or manipulation, so be sensitive, non-judgmental, and patient-centered in your approach. Empower the patient. Allow the patient to make decisions about their care and support them in whatever choices they make The goal is to provide options, not force action. Empowering patients helps build trust and control over their lives. Create a safe environment to ensure that your healthcare setting is safe and confidential space where patients feel comfortable sharing concerns. And this includes talking to them alone and creating an atmosphere of trust. Education on mandated reporting. Be aware of your responsibilities under mandated reporting laws. Know when and how to report cases involving minors or situations that fall under mandatory reporting guidelines. And know when to include external partners. Understanding when and how to involve agencies such as DFACS, law enforcement, or other trafficking response teams is essential. So again, final thought is our goal is not to get that full disclosure, right? Instead, it's in our assessments, recognizing those signs, not re-traumatizing the patient, and always, no matter what we do in any patient interaction, to provide a patient-centered, trauma-informed approach. And for our victims of human trafficking, that approach can play a very important role in their identification and facilitating their recovery. Thank you for your time for this real quick, broad overview of the medical response. I am going to kick it over to Dr. Boy to walk us through some of the resources that are available.
Hey, thanks, Sarah. The first one I want to mention, and yeah, there we go, is CACGA, which is the Children's Advocacy Center of Georgia. They were awarded the state contract to facilitate the state response to CSEC. So they operate the 24-hour hotline. They provide comprehensive assessments for suspected victims and then work providing case management, building case plans, working to make sure forensic interviews and any specialized medical exams are provided. They do advocacy work, provide intensive therapy, and can make additional referrals if necessary. And they work within the CAC network in Georgia. There are 48 different CACs in Georgia that work to coordinate care and provide that comprehensive CSEC response throughout the state. You can find more information and a list of the different CACs at cacga.org. You can also find out more information about the CSEC response at their website. Moving on from them, looking at some of the medical services for children at the Blank Center here at Children's. We are a medical model child advocacy center. So we are one of the 48 CACs, excuse me, within the state. And we work with a multidisciplinary approach. We work with law enforcement, DFACS, CACGA, and provide the medical care. We provide sexual assault services in our emergency departments. And we provide those services to victims of sexual abuse, but then also victims of physical abuse and neglect from throughout the state. We provide inpatient care, obviously, at one of our 3 hospitals, and then provide outpatient services in our clinic, both at Scottish Rite and in our clinic at Hughes Spalding. So we are available as a resource. The hotline that Sarah mentioned is the Georgia hotline and website. The hotline number is 866-END-HTGA, and that will connect to a phone tree that will give a variety of options. So option 1 is to provide a tip on the GBI's tip line. Option 2 will connect you to services for minor victims of sex trafficking. So that will connect you to the Children's Advocacy Center of Georgia. Option 3 will connect you to CJCC for adult sex trafficking related concerns. Option 4 connects to Tapestry for labor trafficking concerns. They're an organization that works specifically with labor trafficking victims. Option 5 We'll connect for residential intake for trafficked youth. That's the Receiving Hope Center that provides coordination and shelter services. And then option 6 can connect you to the National Human Trafficking Hotline. So if you have a concern that is outside the state of Georgia and you need to get a victim connected to services outside of Georgia, you can do that through the hotline. There's also a website, endhtga.org. You can move on to the next one. One of the newest things in Georgia passed in a recent legislative session was the requirement that medical offices in Georgia be required to post the CSEC hotline numbers. So this is an addition to legislation that was passed back, I don't even remember how long ago, that required the posting in a variety of different locales, hotels, bars, strip clubs, transportation hubs, places like that. Now medical offices have been required to post, and we have taken that same flyer that the GBI produced and made it a little more trauma informed and a little friendlier to victims. It's provided in English and Spanish, provides both the NHTGA number and the national hotline number as required by law. And if you scan the QR code here, you can get it with our logo and without. If you wanted to put your own organization's logo on it, feel free. We don't want to gatekeep a resource like this. So that is available. And then Sarah, you want to touch on the ICD-10 codes?
Absolutely. So if you are a provider, we do have different codes that can be used whenever there is confirmed or suspected. So I have those codes available to you. There's also some links to different diagnostic coding that can be used for the ICD-10. Oh, yes, and this is mine too. So Stop, Observe, Ask, and Respond is a National Human Trafficking Training and Technical Assistance Center. And this has launched this Responding to Human Trafficking through the Child Welfare System. It's a module, and it's designed for providers that are serving children or youth at risk for or who have experienced trafficking. This training can provide information on addressing human trafficking in those child welfare settings. So for more information, the link is on there for you as well if you're interested. We have also a number of healthcare protocols and guidelines. We wanted to leave these with you so that you could go to them and look through them and find things that might help supplement some training for you, or things that you might want to bring back to your practice of your practice settings, so that you can update the response to human trafficking among your medical teams. And last but not least, I'm going to kick it back over to Dr. Boy for the national and state resources.
Sure. These are pretty comprehensive lists of resources available. The national resources, again, Sarah mentioned Heal Trafficking. The National Human Trafficking Resource Center has a lot of information on a wide variety of different areas and aspects of human trafficking. So they do have some healthcare specific resources, but then they also have broader information available as well. There again is Polaris's number, the Office of Victims of Crime. They have a lot of information available. They provide training assistance. OTIP, the Office of Trafficking in Persons, puts out reports on a yearly basis on a variety of different aspects of trafficking. The National Center for Missing and Exploited Children, missingkids.com, runs the missing child database. And so one of the things I've started telling people locally is if you see missing kid things on Facebook and you're curious, do I want to share this? Do I not? I really feel bad if I don't share it. Go check and see if they're on NCMEC's list. And if they are, then yes, share it widely. But if they're not, chances are it's a scam. Then the runaway hotline. You can connect Runaway Youth for resources there. And then next are some of the Georgia-based resources. So again, these are organizations within the state of Georgia that provide a varying level of resources. Some are shelter-based and provide shelter services and comprehensive services for victims. And then other organizations like ours provides healthcare and prevention and education services. And then Street Grace and Youth Spark provide different levels of advocacy and education services. So finally, some of the adult resources, particularly for the Atlanta area, providing resources for adult victims. Tabitha's House, the Salvation Army, Faithful Love, and the Table on Delk all provide resources and varying levels of services for adult victims. And I believe that is the last slide. We are open for questions.
Awesome. Excuse me. Thank you, guys. We have a couple of questions in the chat regarding mandated reporters. So I'm going to kind of combine them into one. How does mandated reporting of non-accidental injuries for medical professionals affect reporting on trafficking/abuse? I was under the impression we were mandated to report any trafficking/abuse. And if you could clarify on the mandated reporting for under 18 versus adults, that would be great.
Yes, you are required by law to report non-accidental injuries, so abuse or neglect. Trafficking is included in that for people under the age of 18. If they are over the age of 18, you are not required by law to report. And in fact, doing so without the patient's consent could put you in violation of HIPAA. So you do not have to report. Now, if it is a vulnerable adult, so an adult with disabilities, developmental disabilities, or an adult over the age of 65, then it needs to be reported to Adult Protective Services. But adults without that vulnerable status, you do not have to report trafficking or other forms of non-accidental trauma. Carla, you're muted.
Thank you. Y'all got on that really quick. Are there any other questions that you guys want to drop in the chat? We've got a few more minutes and we can address those. I'll give you guys just a second to type those in if anyone has any additional questions. And Alina, if I've missed any questions, feel free to pop in.
I mean, just for Angie and Sarah, it seems that there's a lot of questions about the resources and getting access to those. So just, I already said it in the chat, but we are going to be sending out a list of those resources that Angie and Sarah mentioned, and then some additional ones that the task force has been able to collect. And that, of course, will be sent out after this one, but after all of the different series that are in this part 3 series.
Okay, great.
And
Thank you.
I do want to mention one other thing. We do offer an on-demand training on child trafficking and the healthcare professional that can be taken at your convenience. It's available on our website, choa.org/CP training. And it does have continuing education credit attached for nurses, physicians, social workers, law enforcement, etc. So that is another resource that goes into a little more detail on the exam and goes into a lot greater detail on presentation and how victims may appear when seeking services. It is geared more towards child victims.
Awesome. Thank you. Thank you for mentioning that, Angie, because really what we wanted to do, the goal of this series that we're putting together is to really reach out to the medical community and give a basic overview, give you the signs to look for, and then provide you with the resources that you guys need, that you can dig down a little more. And definitely lean on Children's Healthcare of Atlanta. They have excellent webinar resources to give you a much deeper, more detailed dive into this topic. I do want to point out that Alina has dropped a link to the certificate of attendance for today, as well as a survey. Please do take that survey, y'all. We go over, our work group goes over past surveys when we're looking at new conversations with an expert that we need to plan, and we want to make sure that we're doing things in a way that is as impactful and useful as possible. So please do fill out that. Alina has also dropped her contact information into the chat. If you guys need additional information, please reach out to Alina. And if there aren't any more questions, I'll just go ahead and wrap up. I really appreciate Angie, you and Sarah for coming today and sharing your expertise and really getting the ball rolling on having this conversation with Georgia healthcare professionals and helping us get the word out on what human trafficking, both sex trafficking and labor trafficking, look like in a medical setting. I see the certificate link does not work. We will send that out with a follow-up email if that is not working today. So we will take care of that. Part 2 of our series will be on October 24th. And with that session, we're going to pull the lens back a little bit and look at a more statewide perspective. We'll look at what the multidisciplinary team response looks like. We call that NDT. What that NDT response looks like for the state, and the role that the medical profession, medical professionals play as part of that multidisciplinary team. And then there will be a part 3 panel discussion on November 19th. And so we'll bring all of our speakers back together. We'll collect questions. If you think of any questions after this meeting, please send them into Alina. We'll be collecting questions, and we'll be using those questions to help drive our panel discussion on November 19th. I think that's everything. So you've got Alina's contact information, and I'm just going to flip back through here to make sure there aren't any questions that I have missed. And it looks like a lot of them are about the survey link and certificates. So those will also, if you can't access those today, those will be coming out in an email probably tomorrow or in the next couple of days. We hope to have this session of conversations with an expert on the CJCC YouTube page, and we will send out a link to that as well so that you can share that with your colleagues, share that with other medical folks in your network. So if that's everything, we will wrap up and sign off. Thank you again, everyone, for joining us today. And thank you, Angie. Thank you, Sarah, for bringing us a very informative and impactful program. And we will catch you guys at the next Conversations with an Expert on October 24th at noon. So look forward to seeing y'all again soon.
Thank you all.
Why will it not?